You are personally responsible for the education you choose. Okay, so if you go on a course, an implant course, and it's basically, a week course, and I fly off somewhere and get some poor unsuspecting victims and smash 20, 30 implants into their jaw and then come home and become an implant surgeon, you're responsible for that course.
Hey guys, welcome to the CPD Junkie podcast, where we bring you interviews with dentists sharing their CPD stories and journeys from around Australia.
Hey CPD Junkie fam, I'm your host Laurence Doan, and today we're joined by Dr Bobby Chhoker. Dr Bobby Chhoker graduated from the United Medical and Dental Schools of Guy's and St Thomas Hospitals with a Bachelor degree in 1997. He then went on to complete a master's degree in Implant Dentistry from the University of Warwick and is an invited member of the International Academy of Dental and Facial Aesthetics in New York. Dr. Bobby Chhoker, welcome to the show.
Thank you for having me.
So tell us about your CPD, your dental journey so far, and how did you develop a special interest in implant dentistry and TMJ disorders?
Well, two separate things. I'll deal with the TMJ disorders first. I just found that at an undergraduate level, which I think still sort of stands, unfortunately, today, that occlusion and TMJ isn't taught at a very high level. It's taught at a very basic level. And if you think about it, the TMJ and your occlusion is the physics and the functioning, the mechanics of your jaw. So, if you don't respect that or know about that, anything you then put in there, you can't expect to have longevity. And that's, my main problem was I was getting lots of patients with conditions, and I felt like I couldn't treat them. So with the TMJ part of things, I actually went over to the US, to Florida, and did a course with the Pankey Institute and the Dawson Institute over about 5 years. Pankey did a few small little boot camps, but I did the whole curriculum for the Dawson Academy, which I sort of liked their actual philosophy. And that helped me greatly. And then, when I came back, I just set up the TMJ clinic because there seemed to be a number of cases and a need for it. Okay, so that's how I went about the TMJ part. With the implant part of things, I think for me, and this doesn't have to be, you don't have to be naturally good at something and without me trying to blow my trumpet and try to be as modest as I can. I just felt that I excelled at surgery more than anything else as an undergraduate. Had a feel for it, had interest in it, and you never know what it is, chicken or egg, whether because you're really interested in it, you become good at it, or you're good at it and therefore you become interested in it. But either way, I think, I'm a firm believer that everybody can be taught these skills over time, and it isn't just like any form of sort of natural talent, although that can help. And the CPD part of it started at the beginning. I sort of went on the same thing. We run a boot camp. We've actually got one coming up next weekend, and it's an introduction for dentists who are beginners to get into implant dentistry without having any judgment or anything else. We know you're novices and taking it that way, and that's exactly how I started, and that's why I probably run that. I went to sort of like a boot camp. I said, well, okay, implants. We weren't at that stage, which we weren't taught anything at all on at an undergraduate level. We just knew what an implant was, and you knew to sort of make up a crown, a button, the implant, the fixture itself, and that was it. Right. It was mentioned, I think, for 10 minutes in the lecture, and that was it. At that stage, so I was like, okay, I'm interested in this, and I went to sort of like a weekend boot camp. At the time, it was run under a teaching academy called GIFT by Stuart Harding. And it was in conjunction at that time with GIFT was the sort of startup part of it, and it bolted onto a modular form of formalized and accredited qualification with the University of Warwick.
Right.
And so ultimately Stuart Harding became my mentor, and that's like, one of your previous episodes rang with me, because I'm a very firm advocate of mentorship, and but you need to make sure that you're a good mentor. You can't, I see at that time there were a lot of courses. I went to courses, and there's always a dangling carrot. You know, I understand with a boot camp, you can't teach everything. And I tell people that this is just a startup to get you into it. You can start assessing some cases, and with some guidance, you can even maybe start treating some cases. But, you know, step by step, very carefully, to keep you and your patients safe. Okay. But I found there's a lot of sort of dangling carrot, and, you know, some of these courses were based around realistically, you know, gaining referrals, etc. I don't want referrals. I have enough patients. I want you to treat the patients. Okay. So Stuart Harding, when I went to his thing, there was none of that, and there was a formalized course as well. So, you know, I embarked on that almost straight away. I started placing implants under his guidance for quite a while before I did my MSc, for many years. I qualified in '97, and when I came out, he asked me to become part of his practice in Harley Street, which I was very honoured to do, because it's quite difficult to be in at that level, you know, when you start straight away. So I got a very good start, as it were. And he's always reminded me that, you know, he gave me a good start, I should be giving other people a good start. So, you know, here I am.
So I'll just backtrack. Yeah, I mean, you came straight to the point. So you graduated, and you were cherry-picked, weren't you? You were cherry-picked by him to go to his practice and start working there. Is that kind of where you saw, okay, TMJ is kind of like where I want to kind of dive into it, and that's how all the Panky stuff kind of came into it? Or was that kind of later on that you decided that TMJ, after you were doing all this oral surgery and all that kind of thing, that kind of came into the perspective?
I think slightly after. I mean, you know, I wish I had been actually before, but slightly after, but it's simply because most problems you get, particularly, you know, that occur over long periods of time, are with occlusion and TMJ. And, you know, if you don't have a stable reference point or somewhere that you can make stable if it's unstable, which is reproducible, you're pretty much all over the place. So, you know, I found that out very quickly. The problem that occurs with implants as opposed to teeth when you're in something that's not in harmony is that with the teeth, you know, they're quite forgiving because they have a periodontal ligament. They will move, they will accommodate, you know, they will take up all these stresses. And they can take all types of forces because they have ligaments designed to do that. And ultimately you may fail. Well, implants don't. Okay, they're not forgiving at all. And one force they don't like is, you know, you have a compression, a tension force, but they don't like shear forces. And ultimately that's what occlusion produces. Okay, particularly anteriorly. And you'll find that, you know, you get bone loss very quickly. The other problem is that once you lose that implant, it takes bone with it. Sometimes you're in a situation where there is insufficient healthy bone for you to then have subsequent implant treatment.
Right. So what you're saying is that you came out, you graduated, and you're kind of working this practice, doing your general dentistry of the sort, and then you're kind of taking a liking to kind of oral surgery and all that kind of stuff, and implants as well. And that's kind of when you started to see that TMJ was kind of becoming a bigger factor, there's bigger issues, and that's when you decided, okay, now I got to go dive more into it and kind of gain a better understanding of it. So that's kind of how. Right, so implants kind of came first. So I guess, sorry, I'm just kind of trying to paint a picture here so then our community can kind of follow on your story. So you graduated, and then would you say that earlier on at that point you were doing simple kind of cases before you decided to do the masters, or did something compel you to do the masters? Yeah.
Yes, it did. I think I went from simple to fairly advanced cases, but the sort of the occlusion, TMJ, and that sort of stage learning really helped me. Because let's just take implants out of the equation. Let's just say we're dealing with a full mouth rehabilitation, which may be, you know, a fully broken down mouth, and let's say there's no implants going in at all the teeth are savable. It provided you with the basic principles for re-establishing a reproducible joint position and then restoring to that. Okay, and doing it in a temporized version that's not going to fall apart, that can then the patient can really wear into, so you know exactly where they sit comfortably, and then reproduce that in the permanent form. So that was like that part of it. I think it just happened that there were a number of large cases that were coming along, and I wanted to know how to treat them. The bit with the implant came later because I saw that by putting things into harmony, you had predictability, Okay, and if it's predictable, you're happy, and more importantly, your patient is happy. You know, happy patient, happy dentist, and very importantly, it had longevity with little maintenance.
Yeah.
Okay, things didn't fall apart. You weren't gonna, cross your fingers and go, I hope those veneers stay on. Now you're confident they're definitely going to stay on. It's impossible to come off, So put your things in a different bracket. That's what it was, and that's why in even actually year one, when we're teaching, as you know, we're teaching the master's degree in conjunction with Stuart Harding again in the UK, and we do a certification diploma MSc, it's 3 years. It's up to you how much you want to do. If you want to do a year, that's fine, where you want to get off that boat. And one of the things that we do immediately in the first year, in the first sort of section, first module, is occlusion.
So you're saying that you graduated and you were you had a lot of these heavy cases. Is that what happened?
Yeah, sorry. Let me just answer the last question. I digress. So what happened was that I got to do these cases, and I got bigger cases. I got to the point where we're treating very complex cases. And once you start treating them, if you break the case down, it actually becomes a simple case, lots of simple cases joined together. That's all that complex cases, like everything in life. The reason I did the MSc is because Stuart Harding wanted me to teach on the MSc, or his part of it, gift, and I agreed with him. It didn't sort of bode well, sort of having a tutor teaching you all this stuff, whether you know it or not, all the experience and everything else, when you don't have a formalized qualification. So I started to embark on the MSc for that reason initially, but in hindsight, it was the best thing I could have done, because the amount of experience it gave me, because you're not privy to what you don't know until you don't know you don't know. Okay, so it gave me privy to so much information, and access to things that you don't have access to. You think, okay, fine, I can go and learn a little bits here. You can. It becomes quite labor intensive. You're working, you're running a business, you've got a family, you've got to walk the dog, and then you're going to come back and dig into these books. And that's why, it appeals to students to have these cases where people have done that for you. But when you do an MSc, you have access to information you don't have access to normally. You have access to journals and Medline and studies that are particular to that university, and all the universities in the UK that have a sort of centralized information source of that. You have access to all of that. And so you get to see and read things and see cases at a much higher level, and that's what excited me. So I initially went into the teaching, but once I got in, I was like, this is great. You're expanding your skill set. You're knowing what to do, because there's nothing nicer than a dentist knowing what to do predictably and with repetition, so that it works, because then they can say to their patient, look, I can fix that, and ultimately, regardless of whether people think they've sort of gone into it for their life, money, or that aside, there's a care element of that, of you, and if you can help someone else, and I think you're smart and you're clever, and it's not an epiphany, because I don't believe in them, because it's just a realization that you've not really got it before. Now you do, so you just call it an epiphany, is the fact that helping someone else really makes you happier than helping yourself, you see, as far as the space. So that's I think that was part of it.
Yeah, so you're saying that you weren't aware that you're doing all these, like you said, boot camp, weekend kind of courses on these implants, and it wasn't until you actually dived into it that you really kind of understood that, wow, there is that big jump and that difference in it, doing a master's compared to a weekend kind of course.
Yeah, yes, I mean, I think, look, weekend courses is not bad for you to get a feel, because it may not be for everybody. Owning a practice isn't for everybody. Being a businessman isn't for everybody. You're not taught that undergraduate level to be a businessman. Yet you're thrown straight into a business, whether it's somebody else's or yours, So it gave me a feel of, feel out what you like, go and explore. You're young, you come out of college instantly, people are, oh, yeah, well, now I've got to do this, relax. Okay, take your time, there's no hurry. There's no hurry, really, there's no hurry, enjoy it, And time flies, it just disappears. You just got to be present and enjoy it. And find out what you like. You might embark on implants and say, I hate this. I want to go do something else. You might even graduate. I have colleagues of mine that have graduated, dentists, very good dentists, been doing dentists. One of them does dentists for about 15 years and decided they didn't want to do dentistry anymore.
Yeah, well, I mean, that's the thing. Like, so many graduates, when they graduate, they're like, oh man, I really need to learn orthodontics. I need to learn implants right now. Like, how do I do it all really quickly and do it, you know? So, I mean, what's your advice on that? So, what you're saying is like, you know, do one at a time and then, or you just say, and then kind of see how that kind of goes, if you like it, and then go from there, or?
I think so, to get a passion for it. Two things. I'll answer that question two ways. That firstly, your why has to be strong. Okay, why do you get up of bed and go in? If your why is completely about money, I want to get a nice car, I want to get a bigger house, I want nicer holidays, look at so-and-so, he's a super GP, I want to be, it's money orientated, it will fizzle out very quickly. You'll become unhappy very quickly. Okay, I'm not saying that that shouldn't be part of it, because we all want, you know, those things by as sort of luxuries, and but like if that's your only way, it will fizzle out. And same in business, you know. But so you'll find your passion. I personally believe, and you know, I honestly hope that people don't think the sentence because I run a master's degree. The reason we did that, sort of reverse engineering it, was exactly that question, because I think you should concentrate on one thing first. Okay, not only one thing, but let's just say your passion seems to be implants. You know, that's why we put this thing into a modular thing, because people do a year certification. So if they decide they don't want to do it after that year, they leave with a certification, a university certification, okay, which is really important. If they leave after 2 years, and they can have a gap of 2 years in between, they don't have to run it concurrently. They can go off and practice and say, yeah, I'm loving this, I want to go back and learn more. Second year's diploma, and then, you know, your third year do an MSc. I think having that formalized and accredited qualification is really important. And it will give you, I don't think you'll really get a flair and feel for all of it until you do something like that. Am I saying you shouldn't do other courses? No, my associate, I've got a great astute associate. He's going to shoot me for mentioning his name, Peter Wu.
Yes.
I think he's great. He's really got loads of get up and go, super happy chappy, and that's what we like at our practice. We've got a lovely team, actually. All of our team are fantastic. I really have to say they really look after our patients and look after me. So, and he's joining the MSc next year. That's not a requirement, that's his choice. If he said, no, I don't want to do it, that's fine. He's a good associate. I don't care about that. That's the career part of things. But he said, look, this is what I want to do. I joined that, but I said, in the meantime, I'm going to do like a small mini residency, mini course in ortho, because I'm really getting into my clear aligners, you know? So why not? You know, there's time for that. You know, if, again, with this MSc, we made it part-time to make it easy for people, because you can't have people doing full-time MSc trying to earn and progress their career. You know, it has to be part-time. Our clinical is 12 days in the year, which is the learning part, really. It's between 9 and 12 days. And then they have access to the surgery, so they can come and see procedures and assist with everything in my surgery. It's like their surgery. And then they have an academic side with Stuart Harding. And so it just makes it easy for them. Yeah, and that's important. And what's really important that people don't understand, and that's why I love the fact that you're doing the CPD podcast, and I really love the fact that you're doing CPD Junkie, it is the fact that this is something that people don't know. You are personally responsible for the education you choose. Okay? So if you go on a course, an implant course, and it's basically, you know, a week course, and I fly off somewhere and get some poor unsuspecting victims and smash 20, 30 implants into their jaw and then come home and become an implant surgeon, you're responsible for that course. Okay, so if you come back and things don't go right and you're up, you know, for God forbid, in front of dental council or legal or worse, they will have to look at your course and see whether or not it's to standard. Okay? And it will actually act against you rather than for you if they find it's well below standard. It's better you'd say, I didn't even go in that course. Okay? So that's why it's important for you to have evidence-based, university level, internationally recognized and accredited course. Okay? Because people teaching that course, like myself, I'm actually accountable to the university and Stuart Harding for the level of course I'm giving, and they audit everything goes through fine sieve to make sure that it's of standards. You know? And that's really important, you know. So don't go up there saying, like, you know, I've been on these 20 sort of mini courses. Because people say, oh, I went on a year program. And the year program is, 5 sessions of 2 days. I said, that's a 10-day program.
Mm-hmm.
The year program involves mentorship, and mentorship is essential. Okay, and that's why we try and be really good. I try and be a really good mentor. All my students that come in, they have access to me. They ask questions. We have to, obviously, they try and book in because I am very, very busy, and that doesn't mean I don't have time for them and my patients, but they just schedule it because it's important enough to talk about. It's important enough to schedule. And they bring me cases, maybe cases that they're not going to treat, and they're just going to do sort of an imaginary assessment and treatment plan.
Mm-hmm.
Okay? And we work through the cases together, or they've got a case where things haven't gone quite right, or they've got a case and said, should I be attempting this at my skill level? As I said, I don't like trying to bring it into practice, but there's certain things they're like, look, could you do that bit, maybe grafting, etc., and then it's an ideal, and it becomes a simple case as opposed to being a complex case. So we turn a complex case into a simple case for them, and then they have my guidance, or they're like, I will happily assist them.
Mm-hmm.
So that's being a good mentor, and having a good mentor is key.
Yeah. I want to come back to a few things. You mentioned your associate earlier on. He was doing clear aligners and he's taking a liking to it, so he was going to pick up a few more of the mini residency in ortho. What's your opinion on, learning clear or fixed aligners first, or,
I think, look, the old adage used to be that, fixed orthodontics is always like, the best, right? That was the old adage, because you can do certain things. Rather than rotation and tilting, you can actually have bodily movement, okay?
Yeah.
And that's basically its major advantage. And also, you can be more specific, and you can get down to really fine points of where you want to get things. That's no longer the case, okay? One of our person we refer to, the specialist we refer to for orthodontic cases. I mean, I don't do ortho anymore as well. I only do surgery. Okay, I don't do any general dentistry whatsoever.
Mm-hmm.
And whether it's cosmetic, ortho, anything, nothing. And but with Peter, if he has a complex case, or he needs guidance, or he wants to refer that on, we refer to Vandana Katyal. She runs the POS, ortho course, which is fantastic. Because that's a course I would actually recommend Peter to go on. And she's a very, very good orthodontist. I respect her very much, and that's why I refer my patients to her. And she does almost everything now through clear aligners. And she says that all that old myth of like, that you need fixed orthodontics to achieve these things, you can now do with clear aligners.
Fair enough.
We've had cases that we've said, and she's treated them clear aligner. I was like, no way. And it's come back and I was like, wow, that's amazing. And the convenience of patients having aligners and everything else. Nobody wants to wear. People only wear fixed orthodontics because they sort of have to, or they've been told they have to. And sometimes, if there is a case, to treat it with fixed for a very short period of time, and then they go straight into clear aligner just to establish some parameters. Mm-hmm. But I did do the fast braces. I think that's a great system. I really enjoyed it. I largely went into it not to treat whole cases, although I did treat a number of full cases. Mm-hmm. I went into it largely for refining cases for implant treatment. So, had tilted, over erupted teeth. In certain cases, we even used it for wisdom tooth extraction. Mm-hmm. In conjunction with a mini implant, where you can actually put tension on a impacted wisdom tooth, or let's say a tooth that's impacted, and it's not medially or just impacted, it's just basically submerged, and it's interfering with the ID nerve. Mm-hmm. We've had them where we've basically managed to pull them up and erupt them and get them away from the nerve so that you can then extract them.
Right.
Just to the patient. It's just much easier. So that's the initial reason that sort of got into that. I think it's important for people to have that as part of their makeup in terms of ortho, being able to do ortho. You see it everywhere, and there's a new term that people quite often use now. So rather than periodontitis or peri-implantitis, is orthodontitis. So basically, they know that a malocclusion or with teeth that are crowded in particular, you can't clean that mouth as well as, straight teeth. So that produces periodontal disease. Okay.
Mm-hmm.
And by fixing the ortho, you can actually make it much easier for the patient to clean and decrease the likelihood of them having periodontal disease. So, it's an important part of your makeup. But within our surgery with Peter, because we have a high demand for it and he enjoys it, those two things are equally important. He wanted to embark on doing something so he could do it at a higher level. But, also be aware of what you bring into your practice, as in your hands, as in not like my practice with Peter. I just tell him, treat what you want to treat and what you're able to treat, and anything you don't want to treat, or if you've got a question mark over it, then don't treat it, refer it, but follow it. Mm-hmm. Follow it all the way through. Have a look at the treatment plan, see what they did, learn from it, and see if that's for you. You don't have to bring everything into practice. I've asked recently if I wanted to go through a accredited course and qualification so that I could place zygomatic implants. I was like, why?
Yeah.
I leave that to the people that do that.
Yeah, I see. Were you guys doing home casting impressions at one point?
We've got, I love technology. I love it. Okay, so I'm the worst. I'm the guy that they see coming, so I'm like, I will go in there, I'll talk about every machine, and then in the end I'll go, what's the best one? Which is always the most expensive one. And I'm like, we'll have 3 of those, all right? So we've got a full set where we can do everything. So with my full mouth rehabilitations, we have a system where we actually 3D print the provisional immediately for the patient. Okay.
Yeah.
And that goes in as soon as teeth are taken out and implants are put in. They get a provisional, and that gives us a lot of scope for changing things if we're not happy with it. If there's a chip or a break, we can easily print another one, etc. So we did have a look at it for orthodontics. Now, we've got a fairly decent setup, but it's largely designed for more that side of things, along with retainers and other things. And we found we've got a relationship with a company with a lab that produces them at a rate and cost that it wouldn't really be cost effective for us to set up our own lab unless we were doing a lot of that. Okay, yeah. So it's still going to be a little bit more expensive, but then you have to think about the hassle and the stress of all of that, and is it worth just paying a bit extra and having it there? Also, with a lot of these companies, we make sure we know who we're getting the plans from, and we suggest a plan, a very detailed plan, and then obviously there's an approved plan that comes back, and it's by someone that is actually an orthodontist, not a specialist orthodontist, not it's not going to some lab somewhere across the world and you're just getting some treatment plans. You'll find a lot of these treatment plans are now automated.
Yeah, I hear what you're saying.
Yeah.
I just want to come back a little bit, so because originally your story started in the UK, right? Yeah. And at this point, like you're and you can correct me if I'm wrong at this point. So you're learning about implants. Things are going well. You're doing really big cases, and you become part of the practice at Harley Street, and owner of the practice. Is that correct, or?
Well, what happened first, I was working for Stuart Harding, and then he gave me an opportunity that there were some rooms that were available, because it was a floor. Harley Street is basically all doctors and dentists have been for centuries. Okay.
Yeah.
That's why it's sort of known it's predominantly known in Europe, but some of the people here medical would know of Harley Street. And the building we were in was a bit more of a modern building. The rest of it's sort of quite, an old architecture. And along our floor, there were multiple clinics, and Stuart's clinic had a couple of surgeries that were free, had become free. And he offered me the opportunity, very kindly, to actually hire the space as opposed to working for him. So I was basically hiring space within his practice.
Yeah, and so you got this going. You've got your space going. You've got the tutoring that you've got doing through the Warwick as well. I guess at this point, what kind of compels you to come over to Australia? Because everything's kind of looking like it's pretty good so far.
Well, a few things. One, it wasn't initially there wasn't really a full intention at first. It sort of fell into place. You know, I don't believe in coincidence, and seen that things happen for a reason. And I was here and I was lecturing with actually Professor Edward Lynch, and he was doing quite lectures at that time, 2000 and, oh God, would it be 2013, 14, around about 2013, we were doing lectures on ozone.
Yeah.
Because that was his study, and ozone was a thing, and I was lecturing alongside that, and I basically got headhunted by a group, and so initially the offer they gave me was to come here and sort of run large practice of what I was doing there. The additional advantage to me was at that time was that I wanted to run my own course, and obviously I couldn't run that MSc in the Northern Hemisphere because that was Stuart Harding's, you know, domain.
Yes.
So this, so he kindly gave me license to run that course with the university and accreditations or something. So my plan was always to launch the MSc. That was sort of my bigger thing because I enjoy teaching. I love it. I really like students. I don't think you should teach if you don't like students and you don't like having a laugh and you know, getting on with students and also imparting knowledge. I don't think you should.
Yeah.
And when I was being taught, most of my tutors couldn't stand being tutors. You know, and it showed. You know, they're like, oh, you know, I want to get out of here. You know, and you look back and think, I don't want to be that guy.
Yeah.
So that was important to me, and I really enjoyed teaching. So I thought, look, you know, I've got an opportunity to launch this in Australia. And then lo and behold, before you know it, you meet someone, you get married, and this is where I am.
Yeah, fair enough. And then I guess, so you come here and then you start working as an associate dentist or something, or is it that you decide to open up your own practice at this point?
No, so associate dentist, and then obviously I didn't have my permanent residency in PR, so I couldn't be a sole trader or anything else. So as soon as that's the other thing, you know, I had a journey where I didn't actually have a smooth ride. Sort of when I got anything, why would he not have a smooth ride? You know, got everything like going along, etc. But life isn't that way, and you know that's why I'm very firm advocate of being like a really good principal to my associates, like being a really good principal. You know, really looking after them, having their back, really encouraging them, really inspiring them. You know, and really sort of not to the nitty gritty, you know, let certain things go, you know, but they've obviously got to respond that way. And so I didn't really have that smooth ride. So as soon as I got my PR, I decided, you know what, I've worked for myself virtually all my life, you know, and then I had a short hiatus of working for other people for about 3 years. Definitely go back to working for myself. So I went and did that, and you know, and that's why I sort of mentioned earlier, you know, you've got to know. Sometimes you don't know until you get into it, but you've got to know whether or not you want to be a business owner, because financially it's not always beneficial. It can be if you're at a certain level, definitely, you know, but quite often if you're doing just general dentistry and everything else, if you weigh up having a decent percentage and working in a practice where you've got good quality clients coming in and you're not having to do anything, you go in, you do your work well, and you leave with nothing after 5 o'clock. You weigh up the difference in the amount that you're going to get at that level anyway, and quite often associates go, not interested in like taking on all that burden.
Right. Yeah, because like for a lot of you know, associates or graduates at that 4 or 5 year mark, they start to contemplate being a practice ownership or being a specialist or being a super dental GP. You know, so what are your thoughts on that? Given now that you've been part of, you know, each of those processes.
I think being a super GP, being a specialist, yes. You know, keep learning, carry on learning, keep doing that. You'll just don't have that objective. Just carry on learning. You'll end up there anyway. There's no other way you're going to go. You're going to end up there because all roads, you know, lead to Rome. So with the practice part of it, I think it's good to get a feel of things. In the past, it's, you know, obviously my practice here, but you know, I've had several practices in the UK. And sometimes at one point I've had nearly 4 practices all at once. So I had a look at it, and with my associates, I try and be generous, okay, so that they feel like the difference between owning their place and that is very marginal, okay, in terms of the monetary side of things. And in one of the practices, which obviously I sold the practices as I left, which was great for me, was that one of the last practices was actually an associate from one of the third practice I opened, and when I opened the 4th practice, I opened it as a partnership with that associate. And I gave guidance on how to run the business, how to put systems in place, sort of like a blueprint to help. But I was pretty much a silent partner. I made sure my associate was the principal, not me. And that they ran things. Obviously, they came to me for guidance, so they were stuck and everything else. But the day-to-day running, the staffing, everything else was run by them. All I did was finance it on the other side, because they were like, well, I can either start off with a single room somewhere and slowly try and build up in 3 to 4, 5 years, or I can go in, I can have a sort of 3-4 operator surgery and go into partnership with Bobby, and that means that I can start at the level I want to start, or the level I've been accustomed to, because that's the level they were working at in my surgery. So they were all like that. I'd sort of rip out and get it done really nicely and have the latest gear. So and that's not easy. People tend to forget. There's a lot on young graduate shoulders, and I hope that there isn't that same sort of hierarchy within the system as there used to be in hospitals, where all the nasty rolls downhill to them. Okay, and in a private sector, we've got liberty to sort of help people like that. And my team make me. They're very important to me. So, I always make sure that they're happy.
Yeah. So I'm just coming back to the implant side of things. So how did you go from, doing singles, multiples to, now, all on 4, and then is it Teeth Express as well? Like an all on 6?
Yeah, I mean, they say all on 6, to be honest, whether you call it all on 4, that's just like registered trademark by Noble Eye Care. Don't know why really. But Teeth Express, everybody comes up with their teeth in a box, whatever you want to call it, smile in a box, I'm sorry, and whatever they want to call it. Everybody comes up with their own thing. It's essentially the same thing, okay? And I never say sort of if it's all, it's never always on 4 implants. If more implants is better, that's what we do. We look at the cases of we call them full mouth rehabilitations. We don't use that term. That changed for me in a different way, because as I said before, I sort of learned through Stuart Harding being my mentor, and it wasn't formalized and accredited for me later. But now in hindsight, with the students that I'm teaching, definitely formalized education. The certification, for example, teachers, by the end of the certificate year, you should be able to place a single anterior and assess it for have an aesthetic risk index that we use. So you know how difficult that case is aesthetically, simple, advanced, or complex. You should be able to place a single anterior, a single posterior, and restore a short space, so basically 2 implants and a bridge.
Yeah.
Okay? And you should be able to do socket preservation, and you should be able to assess the patient fully, treatment plan well, and surgically plan, and know your drilling protocols, and also digitally plan if you're going to use a guide. So it's not a dangling carrot. The first year is designed for you to be able to do all those things. Now that requires mentorship. You can't get, we put as much as we can into it, so you've got all the ins and outs. So it's a proper toolkit for doing this, but you'll always need mentorship because that's more of a confidence thing. Okay. Yeah. So we can make sure we supply that. In the second year, they learn to have advanced bone grafting, sinus lifts, and how to do all on form, Teeth Express, smile in a box, full mouth rehabilitations. Yeah. And the third year is academic, where we pass to university. They get a tutor, and this is all done remotely from, I think, University of Bolton. And they can have their MSc if they want to go down that path, which I usually encourage. If you've gone as far as the diploma, so just last year, and do your dissertation and get your MSc. Okay. Yeah. So in terms of answering questions of learning how to go from single, the next step would be, because single would be, it wouldn't just go from single to multiple. The stages in my mind would be, first of all, learning treatment planning and how to restore things prosthetically single unit. Then it would be the surgical part. The surgical part, obviously, the posterior being easier than the anterior. Okay, so go posterior single, anterior single, and then it would go to posterior short space. Okay, if you can master that, you're pretty much, that's about sort of 80–90% of the dentistry that comes to you in terms of implants. Beyond that would be advanced bone grafting, soft tissue, and then beyond that is obviously full bone rehabilitation.
Yeah.
So yeah, that's why sort of we try to run it as modules in that form.
Yeah,
so,
yeah.
And one of the things that we concentrate quite heavily on to help students is that, you know, the course has been designed, the academic side with Stuart Harding, which you have like these little tutor groups that you just zoom into, which is great because you have to take time out of practice. And they're not labor intensive, and they're not like every single week. So, you know, there are enough as much as little as you want, but there's a minimum requirement. It's all evidence-based university level learning. The clinical side with me is basically more the practical application, and that's why it involves a fair bit of typodont and actual clinical learning. And, you know, once you've got that down and you know what the criteria for assessment are, and you just follow that format, it gives you a result. And a lot of these are sort of fill in the box, and it'll tell you whether it's simple, advanced, or complex using, you know, the Royal College of Surgeons criteria. One of the things that we concentrate on quite heavily in it as well is also keeping you protected. So doing things so that they are in line with Dental Council and AHPRA guidelines. So if you follow the templates and everything else, you should stay safe. Okay. Yeah. It tells you your competency, what you should be doing, but also tells you what you should be doing if you are competent to do that.
Yes.
And one of the things we concentrate on most, is consent. Consent isn't just a piece of paper. The piece of paper is important because they say it's not just a piece of paper. If you don't have that piece of paper, it doesn't bode well, but it's a process. Okay. And we also concentrate on note writing, what you should be writing in each of the notes. You know, they don't like template form. Well, they don't like copy and paste. Templates, fine, because you've got to populate a template. And we concentrate on that too. Like, for example, the boot camp, we give them templates on assessment templates for what you need to assess, treatment planning template, consent template, planning template, surgical planning template, and a consent template as well. We give that away. They get my consent, my full consent. It's like, I think it's like 8 or 10 pages long. And there's a section in it that we have where it's the cost. The most of it's generic because it's the same for every patient, but then there's 2 specific sections that are to that patient. One is a proposed current situation, and the other one is proposed treatment. And we populate that. And we also teach students how to populate that in lay terms, because it's informed consent. So if the patient doesn't understand something in the consent form, and you have been through that or documented, that you've given them the opportunity to ask questions and to clarify that there is no ambiguity. And then if I wrote, okay, it doesn't stand for anything. They're like, I was confused, you know, gave me the bit of paper and told me to sign it. So all of that comes into that. And it means that you have happy learning, you enjoy the course, you get accredited, you learn new skills so that you can instantly start to practice implant dentistry, and you can do it in a safe, mentored, nurtured environment. And that's what that's how we do the course.
Fair enough. Yeah. So I mean, like on top of that, because you also have consent forms for like cosmetic smile makeovers as well, don't you? As well. Yeah. So talk to me about a little bit about that too. Like, how's that in terms of your practice and how you do things?
When patients come in for a consultation, let's say for a smile makeover, the very first thing we'll do is obviously talk to them about what their needs expectations are. You obviously have a physical examination and see whether it's appropriate. You don't want to have somebody that's sort of like a 9 out of 10 with perfect teeth who's 19 years old, and you're going to veneer 20 teeth to get them to a 10 out of 10. That's very dangerous, right? You're in sort of dangerous territory. Yeah. But, you know, you need to make sure that it's justified, you know, that it's ethical. Okay, so we assess them. Once we've assessed them, if they're serious about moving forward, we'll do a number of things. We will, number one, take CBCT, and we'll take individual x-rays of the teeth that are going to be treated to make sure that they're healthy, their vitality test, probing pockets, whether it's a CPITN, a BPE, or a 6-point probing chart, depending on what we find. So we do all the basics like we do for everybody else. They have a digital scan. The digital scan is then, we also take photographs, and we then do a digital mock-up of what the teeth are going to look like. So they get that. That's the very first stages to get the blueprint. Once we're happy with that and the patient has approved that, that's then turned into a physical model, okay, by 3D printing, and we create guides from that. And those guides are used then to treat the case so that it is as close as possible to what we predicted digitally, and then physically, and then clinically.
Yeah.
The consent process, the consent process starts from the very point in which, after that initial consultation, because we do those consultations for free, the initial consults, and they're serious about moving forward. So they've paid some money for their diagnostics, and we use diagnostics for everything. Okay, so when I do implants, we do a diagnostics appointment. It's important to gather all the information that we need so we can treat the case. At that diagnostics appointment, the very first one, we introduce the consent, and we talk through the entire consent. So it is protocol in our practice, including for myself, to sit down and talk and read the entire consent to the patient. Then give them a copy to take home, so they've got time to read it in their own time, because it's informed consent. And then when they come back and they want to start treatment and they approve the plan and the mock-up, we ask them to sign a digital form of that, and that goes into their file. So that, you know, that process then, after 2 to 3 appointments, including them having the written consent, to me forms informed consent, because over a period of time it's informed, they've been given time to ask questions, there's no ambiguity, there's no terminology, and they know exactly what the pros and cons of the procedure are.
Yeah. Do you find that sometimes you get in a tight spot when they're trying to pressure you for time-wise? Like, you know, I want to get this done in 4 to 5 months or something like that. Like, do you find that you have to open up the discussion and explain to them, you know, this might actually take a lot longer, or?
Yeah, I mean, I tell them straight away that, you know, their time agendas are not my time agendas. Okay. My duty of care is to them, not their teeth or their lifestyle. But
I've got a wedding. I've got a wedding coming around the corner.
I will give them parameters. So if they say to me, look, you know, oh, well, you know, I've got a wedding in 3 months. Can I get my, you know, I'm the father of the bride, you know, and I'm going to be giving her away, and I need to have my teeth are terrible. Can I get my full mouth rehabilitation done in 3 months? And I'll be like, no, you can't. But I'll tell you what you can have. You can have the surgery done, and you can have a provisional, which will look a lot better than the teeth that you have at the moment, because they're terminal. So your aesthetics will be significantly enhanced from, like, let's say 2 up to about a 6, 7, or an 8. There won't be a 10 until I've got the final bridge. Now, if everything goes according to plan, it takes 3 months for that integration of implants. And when we start your final prosthesis, then it's going to take us probably another 5 weeks. Okay, 3 appointments. So, you know, that's outside your time zone, but that's what I can do. Okay, and keep it at that level. Don't be put under pressure by patients. You're in control of the treatment plan, not them. Yeah, and that's why, you know, each consent is sort of specific to the procedure that you're performing. You know, we have an ortho one, clear aligners. We have one for fixed face, although we don't do that really anymore. We have ones for fillings. We have one for cosmetic treatment. We have ones for crown and bridge. We have one for root canal treatment. We have one for single implants. We have one for full mouth rehabilitation. Do they all need to be adapted specifically to the patient? Yeah, they're designed to be that way, because then it's like specific to the patient. It's not just copy and paste.
I really like how you're talking about, if our listeners haven't picked up, you know, you're talking about all these different systems that you've built up over time, you know, making sure the patient's fully aware, fully understanding of all things before you go ahead. Because what you're talking about is, you know, a lot of these things, these treatments are pretty extensive, a lot expensive time-wise. They gotta really fully understand, because it's gonna be not just a straight kind of journey. It's gonna be ebbs and flows. There's gonna be soreness and all of that through it. And so they have to be really invested in it to kind of proceed. But I want to ask is like, did you come, like, where did all these processes come from? Like, you know, as a graduate, I'm graduating, and you know, how do I think of these things that you're talking about? Like, is it through that, you know, I fall a few times before I realize, or am I seeing other people do it? Like, how did you come up with all these processes?
I think over time, now it's better. It's much easier. Things are much easier for everybody now. You know, they're not sort of like, you know, never sound like, you know, the old dentist all the time, but they weren't. You know, now you can go online, you can buy a consent. Yeah, you can go online and say I need some consent, and you can buy those consents. In fact, at one point, I think sort of in the UK, the British Dental Association was selling them. So you could buy them from your trade union. Okay, at cost, they should be given to you free. Right?
The ADA should get on it, hey?
yeah. Well, that's how that sort of came about. I think it came about organically, and then it got to the point where, with these particular ones, we actually put them to a lawyer, you know, medical legal lawyer, to sort of, you know, you can never cover everything, but if it covers the vast majority of things, you know, it puts you in safer water rather than safe water. Yeah, I think that's just sort of the way it came about. I think the main fear that dentists have is that if they tell them everything that can go wrong and paint like this scary picture, they're going to scare the patient away, and the patient won't convert, and then they won't be able to do the plan, and they won't get the money coming in for it, and etc., etc. Okay, I think in my case, what I found is that if we're really honest, you know, you don't want to scare the living dead. I just want to say, oh look, you know, there's a chance that, you know, if I put some local into you, you might die, right? You know, you don't want to go to that. I found, in my opinion, I found that when you give patients lots of information, a lot of them shop around now, especially for bigger sort of things, then they find that because you've been so transparent and honest with them, they really respect that. Okay, and they usually come back to you because, you know, there's no point in going to somebody else and they don't tell you the entire truth, and then, you know, you're like, oh, everything's be rosy. If they found out that somebody has told me the truth and they've gone to another practitioner who's then told them half the information, they're like, well, they're not telling me everything Dr. Chhoker told me. Dr. Chhoker told me about all the possible risks and complications that can occur, right? And they're more likely to come back and say, do you know what, I'd go with you because you're honest and transparent. So, you know, don't be deterred.
That's fair enough. So, you know, for a lot of our audience, there are a lot of they're more the recent new grads. You know, they always want mentoring, and you, like you've mentioned, you know, you've got an associate. So how do you kind of embrace it? Because some people interpret it differently. Some people think it's being held by the hand. Some people want to be checked in once in a while. Some people want to be a fly on the wall and just observe. I mean, yeah. So how do you approach it, or what are your thoughts on recent graduates when they're looking for mentoring?
Come and meet your mentor. I did a series of webinars, and even that, I invited people to come into the surgery. Okay, we're not going to assess you, look at you, going, what are you capable of, etc. Just come in, meet our team, see what a day-to-day for me is like. You know, what the day-to-day run of things are like, and whether that's what you sort of want to do. But you know, you've got to show up. Okay, otherwise you won't know. I think it's important to come and meet your mentor, find out whether they're the right fit for you. In terms of answering your question about some people want to dip in, etc., I have a set format of what my requirement is in terms of teaching. Okay, and I don't like any less than that, because that then leaves sort of gaps and question marks, and they usually cause problems, and then that's when you end up in hot water. Okay. Yeah. So if there's a certain amount of learning that you have to do to be able to do, let's say, that case, an assessment. Okay. Some people like to go off and do the assessment themselves, like you said, and come back to you and say that this is what I've done. But, you know, and that's what I prefer, with the assessment part of it, and then I can correct rather than holding their hand for the assessment. But if it means holding their hand for the first one to assess it, then at least they've got a gist of what the right thing to do is, and then they can go back and do it themselves. So it's a bit of both, I would say. But in terms of the actual clinical application of it, no, then I'm sort of like completely sitting next to them and assisting until I know they're able to do that for their own cases. And we're sort of pretty much giving them a competency profile profile. So until you achieve that competency profile, I'm there as your safety net.
Yeah. I mean, what happens if, let's say, for example, Peter's like, I've got this tricky case about maybe just trying to understand, the occlusal scheme and all of that, like what factors do I need to consider? And he comes to you, like, how do you suggest he approach you? Do you think he should ask you afterwards, or kind of, I guess, take all the records and ask you afterwards, or kind of, if it's okay for me to kind of come in and then just observing you and doing your cases?
Yeah, a bit of both. He comes in, Peter, like, if he wants to see something, he'll come in. Like, students will ring in and say, what's Dr. Chhoker got on today? I'll do this, and this. And most of my patients are very good. I'll say, look, the student, they're like, oh, absolutely fine. Rare for people to say, I don't want somebody in there. And with assessments and things, what they do is there's a set number of things I want them to, we have a template. They've got to populate that with, patient's history, etc., like you would normally. And they bring that with the x-ray. Sometimes a Zoom call, they're like, oh, this is the x-ray, this is the history, so I quickly read through it, and then we have a chat to say, what do you think? And we have a discussion. So we have a treatment planning session. So that's how we approach it.
Share with us what you hope your ideal clinical or non-clinical day might look like in 5 years' time.
My ideal clinical and non-clinical day in 5 years' time, I am already on the progression of removing myself out of clinical largely, and teaching the clinical only for the teaching part of things, not sort of my own practice. So in 5 years' time, I would imagine that I would be predominantly teaching and only having clinical cases that are associated with students.
And what are some words of wisdom that you would pass to your younger self?
Keep learning and start early. Yeah, that's what I would do. I think by having education is what I would say. Because that, regardless of what happens and doesn't happen, and pandemics and everything else, will always see you through. It'll keep things interesting. It'll give you larger knowledge and therefore more enjoyment of your career, and it'll give you more success.
Fair enough. So we asked a few questions around our audience, and one of the questions was, what's it like being a hand model for, was it Grazia?
Grazia, yeah.
Grazia, yes.
My wife is a fashion stylist, so they had a sort of dental theme sort of thing that they were doing, so they were using surgery, but part of the thing was I couldn't let them be on in surgery without somebody being there. None of my staff wanted to be there on the weekend, so I had to be there on the weekend, and then suddenly I got roped into being that sort of a hand model. It's rather strange.
You can put that as one of your highlight profile career highlights.
I don't know how you dug that one out, but anyway.
And do you still kind of practice your morning routine now, like writing in the diary and exercising and all of that to kind of is that something that you would still recommend to dentists as well? Just getting that mindset and just going through your thoughts and setting yourself ready for the rest of the day.
Yeah, no, it's very important. Very important. I use sort of a thing called 5 pillars. There's loads of these things out there, but generally it's not having devices for an hour before bed and an hour in the morning. No screens, no nothing. I do my sort of Wim Hof freezing cold shower in the morning and boost the immune system. Try and get 20 minutes of exercise minimum in the morning, and 10 minutes meditation. That's the first thing as soon as you wake up. And you don't have to be in some kind of sort of tantric pose. You can be sitting up in your bed and just trying to not have all those normal thoughts that come into your head about the day and worries and everything else, and just clearing your mind, and it sets you up for the day.
Dr. Bobby Chhoker, thank you for coming on the show today. There's so many more questions I want to ask you, but if you can let the people know how they can find you or what you've got going on in your life.
Absolutely. You can find me you can come to the practice. It's open to everybody. Just let us know. We're in Bondi Junction, level 199 Spring Street. Our number is 0280709010. Please go to our website, drbobbychhoker.com.au. It has for dentist section, and there's loads of education stuff going on there. We've got a boot camp which is fully subscribed this next week. We're going to be running more. And for those of you who sort of don't want to sort of take time doing this, then you'll really want to get into it and really are focused on having an implant career. We're launching the second year intake from February. We have an intake for our MSc, so the first year certification, we have an intake for that. We start in July this year. It does require an interview process, so sign up, come in, come and have a chat. If you have more questions, come and talk to us.
Awesome. For our viewers, if you like this episode, drop a comment below on your favourite part, but don't forget to like and subscribe, and we will see you in the next episode of CPD Junkie Podcast. Thank you.
Thank you for having me.